Welcome to the Beach RN, education for registered and student nurses. This week we're looking at anaphylaxis. To paraphrase the Australasian Society of Clinical Immunology and Allergy, it's a severe life-threatening allergic reaction. It may or may not have skin reactions, urticarial rash, erythema, flushing and or angioedema, plus the involvement of the respiratory or cardiovascular symptoms and or persistent severe gastrointestinal symptoms or any acute onset of hypotension or bronchospasm or upper airway obstruction where anaphylaxis is considered possible, even if the typical skin features are not present. Look, if in doubt, treat it as anaphylaxis. What's going on at the molecular level? Well, let's look at a mast cell, and it's got these chemical mediators in it. Let's say your kid had peanut first time ever 2 weeks ago, has it today, and it's sensitized. So the peanut molecule binds with an immunoglobulin E receptor and causes degranulation of the mast cell. Not a good thing in this instance. Should be ringing alarm bells. Because what's happening with this degranulation? Well, pathophysiologically, we're having a release of histamines, tryptase, leukotrienes, prostaglandins, tissue necrosis factor, and platelet aggregator factor. So remember, that's generated by mast cell or basophil activation, long been shown to trigger the major physiological manifestations of anaphylaxis. Also, too, nitric oxide is generated by the activation of the nitric oxide synthesis system, and that acts as a potent vasodilator. So we've got masses inflammation and vasodilation. So what does it mean clinically? Well, we've got our blood vessels. They vasodilate, and increased permeability means that we have movement of the intravascular fluid into the interstitial space. So clinically, what are we seeing? Inflammation, vasodilation, increased capillary permeability. So we're seeing swelling, airway edema, decreased blood pressure, increased heart rate, skin changes, respiratory, cardiac, and gut effects. So it can be one, two, or more of those. Treatment: remove the allergen and lay the patient down flat. And the treatment is adrenaline, adrenaline, adrenaline. We use 1 in 1,000 IM mid-anterior lateral thigh, so middle the side of the thigh. Send for help and then give adrenaline every 5 minutes if there's no improvement. In between, you can check the blood pressure, the SpO2, oxygen if required, and IV access. But adrenaline always comes first. The adrenaline dosing, this is taken from the Australian Immunisation Handbook, and ASCI has also adapted it too. So what we're looking at is the approximate age of your patient, and we can work out a weight and then the dose. So let's look at less than 1 year, they're less than 7.5 kilo, 1 to 2 is 10, 2 to 3 is 15 kilos, 4 to 6 is 20, 7 to 10 is 30 kilos, 10 to 12 is 40, and basically over 12 years, adults are 50 kilos. So with the infants, you're giving 0.1 mil, and with the 10 kilos, you're giving 0.1 mil, 15 kilos, 0.15, 20 kilos, 0.2 mils. Are you seeing the pattern here? 30 kilos, 0.3 mils, 40 kilos, 0.4 mils, and the major dose, you don't give any more, is 0.5 milligrams in one go. Just want to focus on drawing that up. You need to use a 1 mil syringe with 0.1 mil gradations in it. In this instance, we've got 0.4 mils. So that's for a 40 kilogram child, roughly a 10 to 12-year-old. Make sure you understand how to use these syringes and practice drawing up imaginary weight-based doses. Now, we need to be aware of auto-injectors, a lot easier to use than drawing it up yourself. But if you're a school nurse, you work in a general practice, or you might be giving first aid to someone who's got their own auto-injector and they're having an anaphylactic reaction. There's the EpiPens and the Anapens. The EpiPens come in 2 doses, junior and adult. So 150 micrograms or 300. These are prescribed by the GPs, the doctors, the allergy specialists, and or nurse practitioners. The Anapens come in 3 doses depending on the age, weight of the child. So 150 mics, 300 mics, and 500 micrograms there. With respect to the EpiPen, how do we use it? Well, just remember, it is blue safety cap to the sky. You pull that off first. The orange end goes to the thigh, hold it in, and it will self-activate. And you need to hold that for 3 seconds. The AnaPen, remove the black cap over the needle first. Right, the safety cap is still in situ, so you're not going to auto-inject yourself. Once that's off, remove the grey safety cap into the thigh, press the red button to activate, hold 3 seconds. Now, give more adrenaline if available when the patient doesn't improve after 5 minutes. The signs of anaphylaxis continue to progress, or they improve and then worsen. And if at any time the patient loses consciousness and they're not breathing, commence CPR. Transfer the patient to hospital via ambulance for at least 4 hours of observation, and don't let them stand. If you let them stand, they can have a catastrophic drop in their blood pressure. Remember, treatment suggestions presented here are just that, suggestions. Always consult your facility's clinical practice guidelines and ask if you don't know. Tune in next week for our next RN and student nurse update. Thanks for watching. This is the Beach RN, brought to you from the beautiful Mornington Peninsula in Australia.